You can ask questions during this presentation. I expect some of you to perhaps be upset by what you see. That's a good thing. The discussion is good. Okay, so the complexity of recovery and return to sport. So already those of you who gave Michael a well-deserved round of applause yesterday about simplicity is the answer. You're hearing what sounds like an opposite message today, so I cannot wait for your questions. We will resolve the issue. Okay, this is my statement of warning. What does this mean? It means I'm going to present to you a new rehabilitation paradigm because I don't think we do it very well. And I'll present data about why I don't think we do it very well. And none of us are absolved from this, by the way. There is a lot of evidence in this presentation, otherwise I wouldn't give it. However, have I taken my paradigm and tested it as it is in a large randomized controlled trial? No. So you have to take what you hear in the development stages based on current evidence. How did I get to this thought process? Well, you heard yesterday that I've been very excited about complexity theory and dynamic systems. And then we did a systematic review in the British Journal of Sports Medicine. What made us do this is actually clinical practice. So you're going to hear a very clinically oriented lecture today. And as Dr. Becker sort of hinted at, is the more you do research, the more you realize that even the randomized controlled trials, as we more strictly control all the variables, they look less and less like our patients every day. And so this systematic review would show exactly that. When we went and looked at what the evidence was for what people are doing to rehabilitate overhead athletes, it resembled nothing like what people are doing clinically. So the research was very simplistic, very basic exercise approaches. And then when you looked at what expert clinicians were doing, they had a very sort of multi-layered, more complex thought process into what they were doing. So there was a massive gap between research and clinical best opinion. Both levels of evidence, by the way. Are the trials of a higher level of evidence? Yes. Do you discount clinical thought? No. So my focus is going to be on the lower extremity today, which you'll see immediately. What this slide basically says is that in things like ACL tears, whether they're repaired or not, what you see is a high level of re-injury, and in those that get re-surgery, almost all of them, when you look at them under arthroscopy, have signs of osteoarthritis. The other problem, and this is where again I'm basing my thought on we're not doing rehab well enough, is that once these athletes are injured, especially high-level athletes, they're never the same. So there's been more than one systematic review. Claire Ardern has done a couple of them. And what these reviews are basically saying is, look, if we can say we have excellent outcomes, whether with conservative care or surgery, as long as excellent outcomes are defined as you get a normal return of your range of motion and decreased pain, which says nothing about function and returning to your previous level of competitive sport. So not many of our athletes, depending on what review you read, just under half or just over half are actually going back to their original competitive level. That's not good enough, I think we would agree. Okay? Surgery is in the same sort of boat that physical therapy and strength and conditioning are, which is that surgery seems, and you saw this from yesterday, surgery seems to fix the structure, but it is also associated with more surgery, especially ACL repairs. And that data is, by the way, from two American Journal of Sports Medicine articles by Rugg et al. And Wang et al. So here's our dirty little secret that I just sort of discovered surfing the literature, right? Which is that Injury predicts injury, and I think it's because they're never rehabbed well from their first injury. They're close enough. There's pressure to get them back to sport. We send them back to sport. They go back with lots of compensatory sort of strategies for getting the job done, and then they're re-injured again. So as a result, when we do trials of state-of-the-art compared to any other intervention, the state-of-the-art sort of shows up as not much different. They can do unsupervised things, or they can do lesser visits because what we're doing probably isn't good enough. All right. So one thing that I am certain about is something isn't right. It doesn't feel right to me based on this data. So why? So this is opinion. I do think that in a complex world, in a complex environment, not only are we specialized, but we are subspecialized. So it used to be that you were an orthopedic surgeon or an orthopedic physical therapist, and then you were a sports medicine orthopedic surgeon or physio, and then you were that sports medicine physician who did knees only, or you were that physical therapist who was the go-to person that rehabilitated knees only. So we got more and more and more focused, and then we have lots of people involved in rehabilitating the athlete. Now, why do we become more focused? Because information is just massive. So we're trying to get really good at a small thing, but as a result, it ends up with not great communication between all of the different people that are working with the athletes to return them to sport. I think this is the other problem. We see recovery from injury as a line. And I would bet that if you read most protocols after surgery or after injury, they look much like this. In the first phase, you do modalities and some strengthening exercises, mostly in a single plane. Quad sets, straight leg raises, knee extension exercises, hamstring exercises, all in one plane. Once they get better at doing those, we look at whether they've improved some of their biomechanical movement anomalies, and then somewhere between that and return to sport is this massive time window with an undefined intervention when you read the studies. What happens between the improved biomechanics and the return to sport? It's not usually well detailed in these studies. So what is my evidence for why this happens? Well, these are examples of exercises you see all the time that are linear in nature, and yet they're the state of the art for many of the things that we see, right? So, and they are based on, we based return to sport on, the reason the butterfly is there is symmetry. As if symmetry is the one goal that helps you be ready to return to sport. I think that's odd. This doesn't mean it's completely wrong. I just think it's odd that we're expecting exact symmetry when probably none of your athletes is symmetrical. Right? Take a tennis player, for example. If they serve right-handed, are they symmetrical versus their left side? Well, clearly not. They don't serve left-handed, right? When you look at the lower extremity, do we have a dominant leg? Do we have literature that shows, depending on which of your legs you're using, you might use more of a hip strategy versus a knee strategy? We do. So I'm not sure that symmetry is the goal, nor do I believe that these simple basic exercises done in a straight line come even close to getting an athlete ready to return to sport, because that's not what they do when they go back. They don't run in a straight line, for the most part. So what's the result of this linear thinking? Well, we kind of progress them, and then, as I said, there's this giant gap between sort of improved movement and return to sport. And again, you can see Claire Ardern's work cited there, but somewhere between 45 and 55% are returning to their previous level of sport. It just isn't good enough. And by the way, we base most of our progressions on tissue healing. So am I advocating that you ignore tissue healing? No. I think that's important. Am I saying that in some injuries it's unimportant completely, like patellofemoral pain syndrome? Yeah, probably. right? Anything that you call a syndrome is a collection of signs and symptoms based mostly and dominated by pain. And so you are probably in those things not looking at tissue healing correlating to be ready to return to sport. It has nothing to do with the tissue in many cases. You've heard many of the experts talk about this lack of correlation between what we see on MRI and imaging and the actual symptoms that people are having. Dr. Becker talked about this, Dr. Aagaard talked about this. There just isn't this direct linear correlation, and yet we are basing our progression on some sort of tissue healing model in all cases. I think that's probably not wise. So I'm going to give you some brief suggestions from a survey of the literature. Motor control. You heard this hinted at in the last presentation. And there are many ways to define it. I'll do you the honor of not reading you the definition. But motor control seems to be a key component in the recovery of the athlete. That's different than strength, by the way. You can have great strength and have poor motor control. We also know that motor control decreases with pain, and that when we do motor control exercises, it has a supraspinal effect, which, again, perfect from the last presentation, that as you work on motor control and eccentrics, there is a greater than spinal cord effect on what you're doing. Okay? Another suggestion, great from the last presentation. You should probably use eccentrics in your rehabilitation. I know that sounds obvious. Many of us don't except by accident. There's no conscious thought about using eccentrics. You also should probably know that you get some increased muscle mass and girth without doing 100%, 120% of your single repetition max. That simply doing eccentrics early in an ACL rehab protocol can create greater gluteal mass and strength. Okay. We also know that it helps tendons. We have experts in that tendon research here. Why do we care that the tendon is getting healthier and better besides the fact that it might be the thing you're rehabilitating? Well, it seems to have an injury prevention effect, right? In many cases in the lower extremity. When your foot strikes the ground, for example, the Achilles tendon is the thing that lengthens first when all of that force hits the ground so that the calf muscle does not have to rapidly do so, thus protecting the calf muscle a bit. You will hear some people call the Achilles tendon a clutch that helps engage the motor. Okay, and again, here's that citation about ACL rehabilitation. We also know that the Nordic hamstring exercise, and this has been studied several times now, seems to help rehabilitate hamstring injuries, but also seems to have a preventative effect on hamstring injuries. So I want to show you a video, which is, you know, I've said one of our limitations is we always think in a single plane. Right? Doesn't mean we don't rehabilitate multiple planes, but when you have somebody side shuffle, how many planes is that? One. This is what we're thinking. And then to change up our exercise program, we have them use the band, turn this way, and walk with a band around their legs. How many planes is that? One. When they go back to sport, how many planes are they moving in when they plant their foot to cut and change directions? Multiple, right? All at once. And yet we just hope that they'll somehow make that leap from, oh, you did a good hop test and your single leg squat looks good. I think you're almost ready to go back to play. And it's not even close to correct. The gap is too large. So I have been messing around clinically. I told you this is a very clinical-oriented talk. I've been messing around clinically with how do I get exercise to incorporate eccentrics. Now, you'll notice this isn't 120% of your 1RM. But how do I get it to be eccentric, multiplanar, and involve the hip. So this is an exercise we have created. This is about a 65-year-old woman. So notice that she wraps herself in the band. So now you have a rotational force that's happening. And rather than do just a single leg squat, she now has to stabilize against this multi-plane rotation that's going on. And she's also in front of a mirror, by the way, and we'll talk about external feedback and why that is important. Her job here is to let her shoulder come slowly to the opposite leg. This is what happens when we plant our foot, right, to cut. There is always some diagonal movement when you step like this. We don't land like this, right? We don't. There's always this. That's the eccentric lowering of the pelvis. There's a rotational component. There are multiple planes, whereupon you unwind and change directions. Okay? So again, how do we incorporate all of those things? And let me repeat my warning. Have I done a randomized controlled trial that says this exercise makes a difference? No, I am in the clinical thought stage of this, trying to do exercises that look different from everything I've seen but still matter. Being different doesn't have a purpose either, but the method behind the madness is multiple planes, eccentric, and practice lowering that center of gravity, lowering the pelvis. It turns out that much of the quickness you create in your athlete to change directions is greatly associated with how well they lower their pelvis and how quickly they do it. And if you do that well, you're quicker out of your turns. If you do that poorly, you're slower out of your turns. Here's the other thing I think that we don't do very well, which is rate of loading. This study looked at strength but also at bone to show that, look, there is a change in the bone based on the rate of loading. So I was talking to our experts last night at dinner, and I said, do we have evidence that in a pathological tendon, if we increase the rate of load, does that in and of itself fix the properties of the tendon? And experts, the answer was? Experts, the answer was? Yes, thank you. And what, if I remember the conversation correctly, what we mostly talked about is in healthy tendon for sure. In pathological tendon, we know that eccentrics and sustained load helps a pathological tendon, but do we know that if you do that faster, does that speed have an effect specifically? Remember, that's not being completely sure that speed by itself absolutely changed it, but there seems to be what I see clinically is once I believe I have things fixed, once I watch this athlete move and say, oh, okay, so we've got dynamic valgus at the knee, whether or not you agree or disagree with the whole biomechanical model on healing, the point is that there's been some association over time with dynamic valgus at the knee and bad things happening. Okay, so what I see and what I showed you yesterday in a video is that as the rate of loading speeds up, these athletes that you thought moved very well move in a horrible fashion all over again. And yet you are sending them back to a sport where they're going to be running in and around other players and not have done high-speed training to get that motor control at high speed. So my practice is the thing that sort of, again, drives this. What is my practice? I see patients on my own for the last 15 years, meaning I don't work within a health system, I don't get referrals. The patients come to me directly, and very often they come to me after they've had physiotherapy and strength and conditioning. So I want to show you a young lady who is 9 months post-op ACL, and she's been released to return to play because she did the hop test well, and she did an isokinetic test where she was 90% of her other leg with quadriceps and hamstrings. And what I said to her, if you work with track and field athletes, you'll recognize the term bounding, right? Let me see how explosive you can be with each jump. So this is what I ask her. Be as explosive as you can be. Let me see you bound down the track. Now, I wish you could hear this. You might not be able to. But here's her bounding as explosively as she can be. She's a basketball player, by the way. Oops, let me go back one. Explosive? No, that's bloody awful. She can't go back and play basketball that way, right? She could go back. She'll be terrible at playing. She'll want to not return to her previous level of sport. She'll want to give up the sport. Never mind that she can't bound. She also had zero ability to translate horizontal to vertical, which is a great deal of basketball, and she couldn't do that at all. When I asked her to run and plant and take off of her foot, she skidded. It looked like you were throwing a rock across the pond. There was no ability to translate that horizontal force to vertical force, right? Here is a young gentleman who was screened and did very well on slow motion screening. I just want you to watch him jump and you tell me if rate of loading is something that we should pay attention to. The only thing that keeps his knees from going further across the midline is that they slam into each other. That's his one braking mechanism, right? So this is a healthy athlete. He's not injured. He wants to play Division I basketball. Somebody put him through a popular screening thing, which was all slow motion, and found out that he actually tested quite well. He has very mobile hips. He has a beautiful squat. He has all of those things, and that's how he jumps and lands. Now, can I tell you for sure he's going to get injured? No, that's not the message. Is there some dynamic valgus there that's been associated with an increased risk of injury? Yeah. Does he dissipate force well and efficiently with muscular activity, or does it look like he simply defaults to his knees banging together, right? That is not the kind of athlete we want to send back to sport. Those are all physical things and suggestions to change your rehab, to make it more complex. Here's some other things that you know well. Fear is a big problem in trying to return to sport. Fear of movement, fear of performing at your previous level, fear of that first contact, fear of moving at high speed and cutting. Both Podlog and Ardern found that the 3 pillars of self-determination theory were found to be related to return to sport after injury. And I know what you're thinking. Well, wait, this isn't anything to do with what I do. It absolutely is everything to do with what you have to do. The way you interact with that patient, the interventions that you choose, either build these psychosocial variables to an athlete that's ready to return to sport, or in the case of patellofemoral pain syndrome, if you start talking about chondromalacia patella and the generation of the cartilage and how, boy, if you move that way, you're doomed, you actually decrease their chances of ever going back to their sport and make them more reliant on you as the practitioner. That is not the kind of things we want to shoot for. So let me talk about this further. If you've never heard of self-determination theory, it is just a lens by which you look at through the psychosocial aspects of return to sport. So I would change, you can see the definitions up there. I have a different take on these, and I'll give you some different definitions. So competence, belief in the ability to overcome challenges. In much other literature that you read, that is called self-efficacy. Okay, so I'm going to break your heart if you're a physio. I went and looked up effect sizes. Effect sizes are just a fancy statistical term which means how important is your intervention? How big of a bang do you get for your buck? So if you do a quad set, small effect size. If you do manual therapy, I know we all get trained in manual therapy. It's not that it's not important. Small effect size. If you build self-efficacy, much larger effect size than anything we do physically in most studies. What is self-efficacy? You are building their belief that they will get better and that they will return to their sport. If you are filling their head full of nonsense about all the pathologies that are in their knee or their foot or their ankle or their hip, and how all these terrible things are the reason that you can't get better, you have inadvertently taken away all of their self-efficacy that they will ever get better. So watch your language, and it is part of what we do, all of us. Relatedness, sense of belonging. If you believe in that model where you've told them how everything is wrong with them, how horrible it is, what's the first thing that most people with patellofemoral pain tell a runner with patellofemoral pain? What's the first thing they tell your patients if you have patellofemoral pain when you run? Quit running. Right. What does that do? Well, if they were a member of a team and they have all of these social interactions, and runner is how they define themselves, you have now pulled them completely out of that circle, and now they're out here alone. So this concept of relatedness, a sense of belonging, is taken away from them. Now, does that mean we can't ever tell an athlete that you should stop running? Probably if you have a stress fracture that's not healing, you should stop running, right? It's not what I'm saying. What I'm saying is sometimes we pull them from a sport without knowing full well that the imaging that we just saw and that the clinical tests that we just did correlate very poorly with why they actually have pain, and yet we'll just pull them out. So I just want you to think about that as you work with your patients. Autonomy. It's defined as independence and self-motivation. If you look at other literature, it will be called an internal locus of control. It's related very closely to self-efficacy. If you have an internal locus of control, it means you believe that you are the answer in getting better. So, not having been there, and I'll let Michael comment afterwards, but I would say the reason advice works well is they said, look, this is what you need to do, and this is how you do it, and you can do these exercises at home, and we believe these will make you better. Well, you've already told that patient that they have a big part in whether or not they get better. That's an internal locus of control. What's an external locus of control? The only way you can get better is you come to me, the master physiotherapist with the magic hands, and when I lay hands on you, you will get better. And if I don't lay hands on you, you won't, right? If I manipulate your spine, that's the answer. And if I don't manipulate your spine well, good luck without me. That's an external locus of control. That does not predict that your patient is going to do very well. I am not saying that they can't ever depend on you, that you should never put your hands on them, that you should never do manual therapy. That's not what I'm saying. What I'm saying is be careful of the model of recovery that you are developing. And if it's all about you, if the only time that athlete ever lifts weights, my strength and conditioning people, is when they're with you, we have a problem, right? They do no exercises outside of working with you independently. Okay, so those are all other things to consider as you rehabilitate. How about unanticipated cutting? How many of you practice this? Yeah, we have some that are saying yes. Those with a biomechanical training are saying yes, because this literature comes out, because what happens to their movement pattern when the cutting is unanticipated? Again, even though they did it well in a slow fashion, even though they do it now well in a faster motion, with defined cutting. What's defined cutting? I want you to run straight ahead. I want you to decelerate, lower your center of gravity, and cut left or cut right. Instead of, I'm going to throw this ball at you as you're coming toward me, move out of the way of it, right? That's unanticipated cutting. Some people do it in a fancier way than that. They'll light up a light and have you go either toward or away from that light. Unanticipated cutting, again, changes that movement pattern. It gets worse unless they practice unanticipated cutting. When they go back to sport, right? You know the answer to this already, because this is a ridiculous example. Does the opponent tell them which direction to go in? I'm now going to go right. You're going to need to go left with me. Or do they have to adapt to an unanticipated cutting event? And yet we don't practice it. And we just hope that, this is that big gap, we just hope that someday they will learn that. And the way we hope that they'll learn that is we just sort of send them back to practice and have them start with less intense practice drills, and then might that work? Yeah. I would think we would want to prepare them even for practice, right? You heard this, and I don't need to reinforce it, but remember that load is probably a very important variable, not only in injury, but in how you are returning them to sport. And that means load of specific tissue, but it also means load for the athlete. How many times have they thrown a ball in their return to sport, right? Baseball is very common for slowly increasing those repetitions before a throwing athlete can return. You don't see that much in physiotherapy, where we're doing a count of load. How many jumps did they make in my practice session, in their rehabilitation, in their strength and conditioning session? How many jumps did they make in rehabilitating the lower extremity? We don't even know. We just kind of go, I don't know, looks like you're moving a little better, and looks like you're cutting a little better, and why don't you go back to practice and see how it goes? I'm not saying you all do that. I'm saying that's very often the norm. Turns out external feedback is important. So a great debate between internal feedback and external feedback. Internal feedback is what the people like to say, at least in the States, this is what I hear all the time: fire your glutes. Whatever that means. That's internally directed feedback. Externally directed feedback is outside the body. It's on a change in your motion. It turns out that internally directed feedback is probably good for a new task that you have no idea how to do. Turns out that external feedback is required for highly complex movements. What's highly complex movements? Well, anything your athlete does to go back to sport. So they need to have external feedback. If you are still saying to that athlete, fire your glutes, whatever that means, and they're going back to practice tomorrow, I think you've probably missed what you need to be doing, right? So there's some interesting research here, and Richard Willey was in my state of North Carolina. I've been told that he's now moved to Montana. You know, it was some interesting research, because this is what I always suspected, which is that turns out that if you do a single leg squat well, and you do some hip strengthening, and we put you on the treadmill, these were all in runners, turns out the movement pattern that we are trying to eradicate and make you better at completely falls apart again. So in other words, if you had a faulty movement pattern, and we thought the cure was single leg squats and external feedback and hip strengthening — a lot of people do hip strengthening now for knee issues, right, and for hip issues. Turns out that when you do that slow motion stuff, that's great. When you send them back to running, that same movement pattern you were trying to get rid of completely falls apart again, and that you have to retrain them. And so what Dr. Willey did is take the next step, which is, I'm now going to put you on the treadmill, and I'm going to have a mirror in front of you, so I'm going to change your external feedback. You're going to watch yourself run, and you're going to fix that thing, right? So again, the lesson there for me was the linear thought of, I found weakness, I strengthened it really well so the weakness no longer exists. I found a movement anomaly that I don't like, that I think is associated with injury, and I fixed that thanks to strengthening and motor control and all of that practice. It does not translate more than likely to sport. Now, this was only about running. Can I say that about every sport? No. Do I suspect it's probably true? Yeah, I suspect it's probably true. I showed you yesterday a picture of the young lady who does everything beautifully, who doesn't have any pain and injury. We had her hop 3 times on a medial hop test, and the dynamic valgus, which we didn't even know existed, was alarming. This is a slow, controlled exercise, an example of how we're using external feedback. This is, by the way, my practice as I get further into it tends to be incredibly simplistic, and I get excited about little things. The most exciting part about this to me is that mirror isn't made of glass. It's some kind of plastic polymer, which makes it very light. I can carry it like this around the clinic, and if it tips, I don't want to have to worry about glass breaking everywhere. So a lot of my athletes are working with mirrors. All I want her to do is land and control that landing. And notice you don't hear me in the background. I'm not saying fire your glutes. I'm not saying keep your knee from going to the midline. I'm letting the athlete make errors, correct errors, learn from those errors. That tends to translate better into more complex movements rather than you fixing what they do every single time. So how do I arrive at all this mess? And I expect the questions to be hot and heavy. Well, I've told you I've gone down this well of dynamic systems theory, right? We talked about this yesterday with injury prevention. Human beings are dynamic systems with many systems within the body. If you just start naming systems within the body, cardiovascular system, neuromuscular system, endocrine system, digestive system, we're full of dynamic systems. And then an athlete in a sporting environment is part of even more dynamic systems. There are multiple considerations, multiple constructs presented in multiple variables. People are starting to get this idea of the complexity of rehab, and they're trying to capture it. You'll see different models, so I'll show you a few of the models. You may have seen the START framework, right? Notice all the variables that are at play up there in return to play. We are looking at evidence and what functional tests tell us. We are balancing the patient's time of year that it is. So do you always wait for tissue healing if the big playoff is coming up? They got a mild ankle sprain. You're going to wait till the tissue heals? Or are you going to do your best and see if you can get them to play in the last game? I don't think we always wait for tissue healing. So there's other things, competitive level, position played, all of those things. And then there's things that the clinician has to worry about. Lots of variables. This is just one way to try to capture the dynamic, complex systems at play when you're returning people to sport. You can find this in the British Journal of Sports Medicine. Here's another one. This author advocated treating it like a project, that every athlete is a project. And when you have a project like an athlete, you have to look at some very specific things, like coordinating the team to talk to each other so that communication is paramount. You have to look at things like optimal loading, psychological support, nutrition, and logistics. You have to look at what time of year it is. You have to look at functional things. And we all have to plan this outcome and be speaking to each other because it's complex and dynamic. This is just another way for somebody to say, we have to do better at coordinating the complexity of the system. We have to talk to each other better. You saw my version of this yesterday as it involved injury prediction. This is return to sport. These are all things, same concept as yesterday, except these are all things that have been associated with return to sport or impeding return to sport. And I told you I'm also down this deep well. I'm looking at modeling. So when you model all of those variables, and you say that each variable is important as the other, so in other words, each variable has a weight of 1, this is what you get. This big ball of yarn, right? If I weighted in this that, for example, load, as defined by Tim yesterday, is more important, the shape of this ball of yarn would shift more toward load. It would not be a perfect sphere. It would mean that load is highly important and related to other variables. Let me explain that a little further. I don't want to lose you, but let me go a little deeper into this. So why do we think load is important? Well, if there's too much load, injury risk goes up. Fatigue goes up. Well, fatigue is another variable that predicts who's going to get injured. Coping skills, as fatigue goes up, go down. Well, that's another variable within the system. So here is load changing and having an effect on many other variables within the system, which shifts the shape of this system. If we use the hurricane analogy from yesterday, the hurricane does not spin like a top. It spins like this. It is not a perfect circle, so this model can change. What do I think are my big attractor variables, the strongest variables in this? Well, load, self-efficacy and internal locus of control, and psychosocial variables. I think they probably have a greater weight to them than the manual therapy that you're doing. Sorry. Doesn't mean I think manual therapy is unimportant. It means I think that if you believe that manual therapy and strengthening exercises are returning that athlete to sport, I think you are drastically simplifying your life, and it probably makes you feel better, but it isn't. I don't believe that's how it works. Here's a suggested paradigm, and so you said, wait, you just bashed tissue healing. No, I didn't really. Tissue healing is important. You can't ignore the fact that somebody's torn their ACL. Can't ignore the fact that it's been repaired and that it's not a stable structure just yet. But it isn't the only thing you should be looking at. You should be thinking about changing the load, the difficulty, the unpredictability of your exercises as you go. And you should be thinking about moving from local to regional to global interventions. What do I mean by that? Is there anything wrong with focus on the quadriceps after an ACL repair? No, because the quadriceps are inhibited. They're not working the way they're supposed to. If you just look at them, they are atrophied at a massive level. So is there anything wrong with focusing on that? No. That's a very local intervention. Knee, quadricep. What's a regional intervention? Knee, hip, foot and ankle. What's a global intervention? Knee, hip, foot and ankle, and oh, by the way, remember the cardiovascular component? They have to go back to a sport where they run. You'd be surprised how many athletes I get through 9 months of ACL rehab that's been working on correcting biomechanical factors and improving strength, and I say, have you run? Have you ridden a bike? Have you done any hard aerobic exercise to return to the sport of basketball? And the answer is, no, not really. Not really. We've done some sprinting within the clinic, but we really haven't done any cardiovascular training, right? And the cardiovascular is a bigger system-wide thought process. So you have to get beyond these local and regional things to get to broader. Just want to try to change your thinking, that's all. And I have listed it as a line or a stair. Really, it's not. Sometimes you go back to local interventions as pain arises. Sometimes you go, you skip the local and go right to a regional or a global intervention. So it's more of a circular process as you reevaluate. So let me summarize, because I think you've all had enough of my rambling and my suggestion that what we're doing is not good enough. All right, so in my experience, most professionals view elimination of pain and a return of range of motion and strength as the end game. Once we do that, we send them back to practice, we have somebody else work with them, and we hope they get better. It doesn't work. Okay? Second, be careful if you're performing your same favorite exercises for everybody who has the same injury. That's a sure sign that you're not thinking very much, that you're just putting in time. Okay? Almost nobody uses feedback. Well, internal feedback we do. Tighten your quad. Activate it. Okay, but how about external feedback? How about looking at how you move and changing how you move, right? How about letting you make errors and then figuring out what the better way to do it is, right? We don't always have to correct every single micro movement right when it happens. Let them make errors. Now, let them make errors safely. Am I advocating that at week 2 you take somebody who has an ACL repair and say, go ahead and sprint and decelerate and make an error. Let's see how it goes. No, because they're going to tear their ACL again, right? That's not what I'm saying. What I'm saying is, as you get further in the rehab, you have to let them make errors. Am I saying that for my friend yesterday? You should put double their body weight on the squat and let them make errors? No. Am I saying that somewhere as you get up there, should you let them make errors and see if they can correct it without you standing over them and saying, do this, do this, do this, do this? Because you know what? As soon as you leave, there's no learning effect, and they're going to go back to doing the same thing that you told them not to do. Okay? Most exercise programs have about 2 components of strength. They rarely have eccentrics except by accident. We're not thinking that way. We usually move in a single plane. We usually move in a slow motion fashion. We work multiple planes, sometimes at one plane at a time, and we almost never think about the psychosocial variables, the impact that what you say has on that patient, right? Low back pain syndrome is classic for this. The more you tell them about their MRI and the herniated disc and how it bulges, and when you do extension exercise, the disc moves back into place. And that herniated disc makes your spine unstable. Do you know what they hear? Oh my God, I'm going to damage my spinal cord if I move the wrong way. And I have a back that's highly unstable. What is your hope of getting them better? Once you've planted that seed, they'll never believe they're going to get better, right? They're just not. So based on what we know about the data, I would say we need to change to a more complex view of how we rehab to incorporate some of these other components. And maybe you are already. So if you are, great, you can ignore all of this, and sorry for the waste of your time. I would suggest, though, that many people are not using these components, nor would I suggest that you have to use every component all the time, but that at least they cross your mind to do something a little different than Karen yesterday talked about social norms and change in society, right? So for a long while, we did almost no motor control exercises. We just did straight strengthening stuff. Well, then once motor control exercises became the norm, everybody did these really slow motion exercises designed to correct the faulty movement pattern. And then we got stuck there, as if they never moved fast, as if that was the end game, and it's not. This was said by John Nyland, actually, in a editorial to JOSPT. He has said it well. Thank you, I'm done. Now what questions do you have?
Beautiful talk, and I think especially the whole point about maybe we lack something in terms of the words we use to create resilience, to improve self-efficacy. That is at least some of the things I see in Denmark that we can be better at, because it's a big opportunity. So we have time for questions from the audience. Yep, I think you can speak out loud.
Yeah. So you were talking about the bonding with the basketball girl.
Mm-hmm.
Obviously, I understand that you haven't, as you mentioned, that you haven't tested, and not everything is valid and reliable. And
Sure.
But have you played around with those plyometric exercises and tests around the plyometric exercises, which could be helpful in the future by building those return to play criteria?
Yeah, so the question is, you have to tell me more what you mean by played around. You mean, do I have specific exercises that I've developed and validated? Yeah, so the question is, with the bounding exercises and getting people to return to sport at high speeds and doing plyometrics, do I have specific exercises that I do? Yes, I have them clinically. Have I validated all of them? No, not at this stage. Mm-mm.
Special equipment, force plates, off-road jumps, or is it more visual at the moment and sound-based or experience-based?
Yeah, so another great question. So I see all my patients in a biomechanics lab that has more technology in it than I know how to operate. There's 3D motion analysis, there's force plates, there are jump sensors, there are inertial sensors. It is tied into EMG. I am surrounded by technology, and most of the stuff I do is very low tech, and look at yourself in the mirror and let's work on this bounding technique, and this is what we're trying to shoot for, giving internal feedback and then move towards external feedback. So there are mirrors everywhere, not so that they can look at themselves that way, but I want them to watch what they're doing and see the difference between what they're doing and where they want to be. So here I am surrounded. I'll bet you there's $5 million worth of equipment that I'm surrounded by, and I'm using a mirror that has cool, shiny plastic over it. It's just the clinical side of me. I still see patients every day. That's why I like being a physio. Thank you. Those are good questions. Sir.
Oh, thank you. No, I'm really grateful for you as a pure scientist and a clinician sharing some of your purest thoughts with us and allowing us to enjoy that. Thank you very much. I just wondered if you had more futuristic thinking in terms of the exercises that you believe we should be offering athletes, clients, patients, whatever you want to call them, because I think that 3D improvisation of yours with a young lady is an amazing intervention, and it's great, as you said, that you are not going to go back to an opponent who's going to say, oh, by the way, I'm going to catch you on the right-hand side.
Right. Yeah, so that's a great question. The short answer is yes. One of my favorite things to do is create exercises that are getting to the goal that I want to get to, and that doesn't mean I'm silly with them. I don't go onto YouTube and look up the fact that somebody decided that they would do squats while on a blown-up ball. That's not what I mean by that. The goal is I was thinking, how do I get a 3D resistance and practicing a motion that is vital to sports, and then trying to create that exercise. And as you can see, it's very low tech. It's a band strapped to a weighted pole. I would venture a guess that if you came and practiced with me clinically, there would be a whole week where you were thinking, those are the weirdest exercises I've ever seen in my life. What are you trying to get done there? So yeah, the short answer is yes. I have all sorts of exercises, and I talk to my colleagues. My colleagues in the lab are exercise scientists and physios and biomechanists, and so I go to them and I say, what do you think of this? And then, so we're in the process of, you would like to know if, in fact, if you're trying to build pelvic stability with this rotational force, you would, in fact, like to know that the muscle you think you're working on there, which is gluteus maximus and medius, is actually working. So that's what we're working on now, is validating some of these newer exercises. But yes, I have all sorts of exercises that if you looked at them, you would say, that's very strange and odd and different. Yes?
When you're working with your exercise with the feedback with the mirror, you make also experience with the...
Repeat the first part again so they have it on camera.
Sorry. When you work with your feedback exercises with the mirror, you make also experience with the audio feedback, because like Greg Lehman is working very often with the metronome on the treadmill for treating anterior knee pain.
Yeah, I use audio feedback not as much as I should.
Okay, but you don't have any statistics or researching done by yourself about what fits better, visual or audio, or is it depending on the patient?
Yeah, no, I don't know that literature at all, so I won't comment. I think it's probably different for different activities. So, for example, it's probably very sport specific. Lacrosse. I've worked with our face-off people. So if you've ever seen a face-off in lacrosse, they are crouched down. They have their hands in a position something like thus, and then the referee's whistle blows and they have to trap the ball and then try to scoop it out to their teammates, right? It happens just like that. So visual feedback there doesn't help them because they're not reacting to a visual stimulus. They are reacting to the sound of that whistle. So in that case, it's probably vital for me, and that's what we used. We started to train their reaction time to a stimulus, and you can find these apps online. It'll beep, and how fast can you hit something? And so that's what we started to do, is work on that auditory stimulus for them. For most of the others, I work on visual, especially for runners, because as you know, their small movement anomaly, I believe, creates an issue. It's not incredibly obvious to the naked eye. It's not incredibly obvious in a low-tech way, but that small anomaly that they repeat thousands of times every week that they run ends up creating these overuse injuries. And when you look at them, you say, wow, that looks pretty good to me. Those are the ones that you have to get, I think, a little more high-tech with some of them and use visual feedback to rehabilitate them.
Thank you. That was a great presentation. I'm just sitting here thinking, do you think that maybe we are keeping the athletes or patients in our clinic too long and not step out of our clinics and get into their practice? Because maybe instead of doing this exercise to stimulate that and this exercise to stimulate that, maybe we just take them back out of the field and have them play lightly against somebody else. You know, actually do the task.
Yeah, no, right. I think you make a good point. It depends on how good the coordination is in the team. That's really what determines it. If I have someone that I trust on that other end, and when I say, hey, just light practice, well, the interpretation of light practice can be all over the place. So I think if we're very specific about what the athlete is allowed to do or not do, I do think sometimes we keep them too long and work on a lot of things in the lab that they could probably be doing outside the lab. Depends on your team, though, as you well know. I expected more hate mail. Go ahead.
Sorry to sound greedy for asking another question, but if no one else is going to ask a question, I might as well take the opportunity. Of your exercises that you would describe as, not weird, I can't remember the word you used, but...
I think I used weird, go ahead.
Okay. Could you give us a few examples for, say, the calf and hamstrings, purely because of athletics?
Yeah, could I do that tonight? Please. I think I have a session with you. I'm happy to show you there. I'm getting the...
Yeah, go all the time. That's a workshop if the guys want to present their work.
Yeah, thank you.
Perfect. Let's give him a final applause.